Am I audible and visible to you? Just give me a thumbs up if I am, and I'll be starting in a while. Right. Hi guys, welcome to today's session. Today I'm here to talk to you about the T&D session in the surgery, episode 1. Let me just check if everything is going on fine, and then I'll be starting up. Just give me 1 minute. Okay, great. So I think I'm live, and yeah, I hope I'm audible and visible to you. Just give me a thumbs up in the comment box. Right? Okay. So yeah, let's begin. Let's begin with the T&D session. So before we begin, guys, what I want to convey to you is regarding our rituals. So what we have done is we have kind of decided the timing on which we will be coming on live or something like that. So yeah, I hope you're able to see in this particular slide. What you're able to see is that uh, I will be coming live on the Unacademy platform, that is on the Unacademy platform at 11 a.m. So every day or most of my sessions will be at 11 a.m. whenever you wish to come and attend it. And on the YouTube, I'll be coming on live at this moment of time, like 12 p.m. I'm live. So yes, on the YouTube, I'll be coming on live at 12 p.m. So from today, what I'm starting is I'm starting this particular session, that is the T&D sessions in surgery, episode 1. And I'm going to continue this from, like, today is the first session, and then it is going to be continued from 1st of July to kind of 6th of July. Okay, 6th of July till 6th of July, we are going to have this particular session. So, you can be tuned to this and you can basically come and attend this till the 6th of July. I hope you'll come and you'll join this. Okay, so today, without wasting any further time, let us kind of begin with this particular session for today. So, the full thickness graft. The first question which we have is the full thickness graft can be taken from the following side section. So what I'm trying to ask is that from which of these particular slides, that is the dorsum of the elbow, scalp, supraclavicular area, and the upper eyelid, from which of these particular places we will not be taking a full thickness graft? Can you please help me with this, guys? What do you think? What is the answer? So in which of these particular places you will not take a full thickness graft? The answer is, if at all you say that the answer is scalp, you are absolutely correct. You will not take a full thickness graft from the scalp. Why? Why? Now, you don't need to memorize it. You need to understand it. Okay. So from what are the places from where you can take a full thickness graft? For this, you need to understand what do you do after taking a full thickness graft. So after you take a full thickness graft from one particular place, it will not grow on itself. You will have to go in for a primary anastomosis. You will have to close that particular skin. Are you able to understand it? So whenever you take a full thickness graft, after taking a full thickness graft, you go for a primary closure. What do? You go in for a primary closure. This is what you basically do. Do you get this point? Now, if at all you want to go for a primary closure, you want some redundant skin, right? Am I making my point over here? So you want some redundant skin, you want some extra skin so that you can kind of pull the edges together and you can take the sutures. We have these skins on the dorsum of the elbow. We have that extra skin in the supraclavicular region. We can kind of just pull the edges and we can take the sutures. We have the skin in the upper eyelid. We do have that, but we cannot stretch the particular skin of the scalp and take the sutures. So that is why the answer is scalp, guys. I hope you understood the basic concept. We take the full thickness graft from that part of the area where we have a redundant extra skin. Okay, everybody got this? Everybody got this concept, guys? Right? Got this? Right. Right. Now let's talk about the next question. So one French. So we have one French. So one French is equal to what? Like, is it equal to 0.33 centimeters? Is it equal to 0.03 centimeters, 3 millimeters, or 0.003 centimeters? Okay. So can you please help me with this, guys? What is one French equal to? Okay. So yeah, what do you think, guys? What is one French equal to? Can I please have your answers on the kind of comment box, guys? One French is equal to what? I'm waiting for your answers, guys. Please put your answers on the live chat. What do you think, guys? You say that it is equal to C. Really? Is it equal to 3 millimeters? It is equal to 0.03 centimeters, guys. It is equal to 0.33 millimeters, which is equal to 0.03 centimeters. Do you get this point? 1 French is equal to 0.33 millimeters. That is equal to 0.03 centimeters. Did you get this, guys? Do you get this? Usually it is given it in the millimeters, but if it will be converted into kind of a centimeters, it becomes 0.03 centimeters. I hope you get this, guys. Okay. Everybody got this? The answer is B. Right. Moving on to the next question. Identify the lesion in this particular image. So I'll just enlarge this particular lesion for you guys. So here you have a thyroid, and here what do you have? You have a thyroid scan in here. You have a thyroid scan in here. Now, in this particular thyroid scan, just look at this and try to diagnose it. What do you think? What is the diagnosis of this particular patient? Is it a cold nodule? Is it a hot nodule? Is it a warm nodule? Or is it a kind of a normal thyroid? Can you please help me with this, guys? What exactly is this? Just have a look at this. What is it? Is it a hot nodule, cold nodule, normal thyroid gland, or a warm nodule? What do you think, guys? Okay, what's the answer? What's the answer in this? So, okay, so you guys are saying that it's a cold nodule, right? The answer is, in fact, it's a cold nodule. Now, just understand this, okay? So what is happening? This part of a thyroid, which I've just encircled over here, this part of thyroid, this is taking up kind of the radioactivity less as compared to the rest of a thyroid gland, okay? So this is taking up iodine less as compared to the rest of a thyroid, and that is why this is the one which is having a cold nodule, guys. Do you get this point? So this is what is a cold nodule, understood? So whenever you get an image like this, what you need to do is that in your mind, you just need to complete the image like this, okay? And then you will be able to find it out. Sometimes what happens, if at all there is a hot nodule, you confuse it, and many times a hot nodule is labeled as a cold nodule by the students, which I have kind of seen quite a lot of times. So please understand, this is what is a cold nodule. Why? Because a part of a thyroid gland is taking up a radioactive iodine lesser as compared to the rest of a thyroid gland. Everybody understood this, guys? That is why the answer is a cold nodule. Now, just a simple question which I want to ask you is that, let's say if there is a cold nodule and there is a hot nodule, what is the risk of malignancy? Okay, so what is the risk of malignancy in a cold nodule? What is the risk of malignancy? What is the risk of malignancy in the cold nodule, guys? The risk of malignancy in the cold nodule is, anybody? Can you please put your answers, guys? What is the risk of malignancy in the cold nodule? It is 15 to 20%. Please understand this, okay? So the risk of malignancy in the cold nodule is 15 to 20%. What is the risk of malignancy in the hot nodule? In the hot nodule, the risk of malignancy is close to 3 to 5%. So you need to appreciate that a cold nodule and a hot nodule, both can be malignant, but a risk of malignancy in the cold nodule, that is 10 to like 15 to 20%, and the risk of malignancy in the hot nodule, that is 3 to 5%. I hope you got this particular point, guys. Okay, everybody understood this? Right. Now let us move on and let us talk about the next thing. So here you have a patient who was brought to the casualty after a blunt abdominal trauma. Okay, so there is a patient who suffered from a road traffic accident, and the patient was brought to the emergency room. Okay, so let us evaluate it further. Okay, the patient was hemodynamically stable. Okay, good. The patient is basically stable. Okay, now what you want, like his vitals were within the normal limits, that's all fine. On the abdominal examination, the patient had signs of peritonitis. But what is happening? The peritonitis, this is basically present in this particular patient. Now, what is the next step in the management of this particular patient? Will you go in for an exploratory laparotomy? Will you go in for FAST? Will you go in for a CECT? Or will you go in for a diagnostic peritoneal lavage, guys? Can you please help me with this? Can you please put your answers on the poll, guys? What will you go for? Will you go in for a exploratory laparotomy, FAST, CECT, or the diagnostic peritoneal lavage? Okay, guys. Yeah. Please help me out. What will you go for? What will be the next step? Like next plan of action? What will you do? So if at all you say that you will basically go in for an exploratory laparotomy, you're absolutely correct. Okay. So what's the answer over here? You will have to go in for an exploratory laparotomy. You might disagree with me, but I'll explain you why. So if at all there is a patient with a blunt abdominal trauma, okay, the patient is with a blunt abdominal trauma, the patient is coming to you, maybe the patient is hemodynamically stable, but as you're able to appreciate over here, the signs of peritonitis are present. Now, do we have a signs of peritonitis? The answer is no. We do not have signs of peritonitis. Okay. The very point that the peritonitis present, this basically tells that there is some intra-abdominal injury. Okay, it basically says that there is some or the other intra-abdominal injury, and because of this, the patient is basically having signs of peritonitis. So it is an indirect indicator that something is wrong inside the abdomen. So that is why you just have to go in for an exploratory laparotomy, and whatever the breach is, whatever the problem is, you have to do a surgical correction of that. Okay, do you get this point, guys? So it is an indirect indicator that you have to go ahead and do a surgery because something is wrong inside the abdomen. I hope you got this point, guys. Okay, right. So even though the patient is hemodynamically stable, we know for sure that something is wrong inside the abdomen. We'll not do a CCT or we'll not wait for fast. We'll just go ahead and we'll operate on this particular patient. I hope you get this point, guys. Okay, right. Now let us talk about the next thing. So Wattersons criteria. This is used for what? So simple thing. Okay, Wattersons criteria. There's a criteria by the name of Wattersons. This is used for the management of what? Where do you use it, guys? So is it used for the congenital diaphragmatic hernia? Do you use it for the tracheoesophageal fistula, for the hiatal hernia, or the achalasia cardia? Which of these particular kind of cases do we use this Wattersons criteria? Can you please help me with this, guys? Can you please help me with this? Where do you use this Wattersons criteria? So Wattersons criteria, the Wattersons criteria in this particular patient is used for tracheoesophageal fistula, guys. Okay, where do you use it? You use it in the tracheoesophageal fistula. Please remember this, right? So no, it is not used for the congenital diaphragmatic hernia. Hi guys, I'm really sorry for the interruption. Really apologizing for that. Okay, so guys, right. I hope you guys are still here. Right. Really sorry, guys. Yeah, I'll explain it. Don't worry. So, yeah, the answer to this particular question is a tracheoesophageal fistula. I'll go back to the previous question. I think some of you guys have not understood that. I'll definitely go back. Don't worry. Let me just kind of go through this and then I'll go back. Right. So, what is the answer to this particular question? It is a tracheoesophageal fistula. Now, whenever you have a patient with a tracheoesophageal fistula, you have to decide whether you want to operate it right away or you want to kind of wait. For this, you have something which is called as a Watterson's criteria. Okay. So, what is this Watterson's criteria, guys? In this, what you basically do, you basically take into consideration the weight of the patient and you kind of take into consideration whether the patient is having pneumonia or not. So if at all the weight of the patient is more than 2.5 kgs and there is no pneumonia at all, you will straight away go in for a surgery in these particular patients. You can directly go in for a surgery. But let's say if at all the patient is having pneumonia, some signs of pneumonia, but weight is kind of between 1.8 to 2.5 kgs, you will still consider whether you want to operate or not. But if at all the patient is kind of having less than 1.5, 1.8 kgs, and the patient is having definite signs of pneumonia, you have to kind of first stabilize the patient and then you have to go in for a surgery. Do you get this point, guys? Everybody understood this? I hope you got this. Now, some of you guys have problem with the last question, so I'll just go back over there. Now, please understand. Why do you want to go in for a CT scan? Why do you want to go in for a CT scan? You want to go in for a CT scan to know what is the problem, right? So you want to basically go in for and to know what is the problem. So the main reason why we go in for a CT scan, it is not to grade the injury or something like that. You want to see whether there is something which is causing some intra-abdominal leakage or arterial rupture or something like that. Are you able to appreciate this point, guys? Okay. Now, this clinical examination, this peritonitis, it is itself telling you that there is signs of peritonitis. You will straight away go in for a exploratory laparotomy. You will not go in for fast. You will not go in for CCT. Now, you can just visit your Schwartz. In the Schwartz, there is a very kind of management of a blunt abdominal trauma. In that, it is very clearly written. If at all the signs of peritonitis is present, you do not go in for a CT, you do not go in for a fast, you straight away go in for an exploratory laparotomy. So please understand this point. I mean, it really doesn't matter whether it is a splenic injury or a bowel rupture or something like that. You have to open the abdomen. So why not just open the abdomen and examine the organs and then try to correct whatever it is present? Are you able to understand this point, guys? Okay. If at all the patient did not have peritonitis, then we would have gone in for a CT scan or something. We would have known if at all there is any injury or not, and then we would have planned the surgery. I hope I have made my point. I hope you understood it. It is correct, right? Do not kind of worry about this. You can just visit your Schwartz and there is a good management protocol. You can basically have a look at that. Okay. Take my words, this is something which we basically do. If at all peritonitis is present, and even if the patient is stable, straight away going for a laparotomy. We do not need CT scan or FAST or anything. I hope you got this, right? Now, let's move on and let's talk about the next question. The next question which we have is Duhamel surgery. Okay, so Duhamel surgery, this is basically used for Zenker's diverticulum. Okay, what exactly is this? Is this endoscopic stapling of the septum? Is it an endoscopic suturing of the septum? Is it a kind of a resection of the pouch or a laser excision? What exactly is it, guys? Can you please help me with this? What is the answer to this particular question? Right. So can I just have a word, guys? Like, what exactly is this? What is the answer to this particular question? So here, if you are saying that the answer to this particular question is a endoscopic stapling of the septum, you are absolutely correct. So what is this Duhamel surgery, guys? This is a endoscopic repair, which we basically kind of do if at all the patient is having some comorbidity. Okay, if at all the patient is having some or the other comorbidity, we go in for this kind of Duhamel's operation. I hope you get this, guys. Okay, so what exactly do we do in this? Let's say this is basically the Zenker's diverticulum, which is kind of hanging like this. The patient is unfit for the surgery. You cannot go ahead and do the open diverticulectomy or something. So what you do, you pass this endoscopic stapler, this blue colored endoscopic stapler, and then it has kind of two prongs. One prong basically goes inside this particular diverticulum, another prong basically stays inside the esophagus. Then what you do, you just kind of snap it off so that the suturing is taking place, the septum is kind of destroyed, and afterwards what you get something like this. Okay, you get an image like this. Now, what is the main problem with the Zenker's diverticulum? Whatever the food you're eating, some amount of the food is going and kind of accumulating in this particular pouch, which is causing the problem, like halitosis, aspiration, and all those things. In this, will the food get accumulated? No, not at all. The food will come and it will go down. Do you get this point? So our problem is solved, and we did not do a very major surgery in the patient. That is what is called as the Dollmann's procedure, which is basically used as an endoscopic stapling for the Zenker's diverticulum. I hope you get this point, right? Okay. Now let us move on and let's talk about the next question. So, okay. So like the small punched out lesions in the lower esophagus on the endoscopy are seen in what? So can you please help me with this, guys? Small punched out lesions. These are seen in which? Okay. So where do you see a small punched out lesions on the endoscopy? Like if at all there is an esophagus and you go ahead and do an endoscopy, where will you see a small punched out lesions? Okay, can you please help me with this, guys? What do you think? What's the answer? So if you say that the answer is herpes simplex esophagitis, you are absolutely correct. So please understand there are three main infections of the esophagus which you need to understand, right? So you have a herpes simplex virus infection. How does this manifest? So this basically manifests as a vesicles and as a punched out lesion. That is a direct MCQ, guys. You need to remember this. Punched out lesions are something which are seen on the herpes simplex virus, and this is what is basically seen on the endoscopy. Okay, now in the candidiasis, if at all you perform a barium swallow, okay, if at all you perform a barium swallow, what will you find? You will find a shaggy appearance. You will find a shaggy appearance on the barium swallow. Then, if at all you perform a kind of a upper G endoscopy, in the herpes, like here we already told that you will have a punched out appearance, and in the CMV esophagitis, you will have a serpiginous ulcer. So please understand this. You have three things. What you need to understand is that in the CMV, cytomegalovirus, you will have a serpiginous ulcer. This is on an endoscopy. In herpes simplex virus, you will have a punched out ulcer. This is again on the endoscopy. And in the candida, okay, in the candida, what you will have a shaggy appearance of esophagus. This is what is going to be on the barium swallow. Do you get this point, guys? So this is what you will have, right? These three are very, very important. These three are the important MCQs you need to remember. Okay, direct one-liners, important MCQs straight from Levin Billy can be asked. Please remember this. Okay, right. Now, why is this candida important? This shaggy appearance, because this is a differential diagnosis for esophageal varices. Okay, so this becomes the differential diagnosis for the esophageal varices. That is very, very important. That is why we have this. Got this point, guys? Everybody understood this, right? Now let's move on and let's talk about the next question. So, a gastric balloon in the Singh-Steichen Blackmore tube. So, if at all you have a Singh-Steichen Blackmore tube, which you basically use for the esophageal varices, okay, in the esophageal varices, what is the, like, how much amount of the air will you push in this Singh-Steichen Blackmore tube in order for that to be effective? So what is the answer, guys? Is it 200 ml, 300 ml, 400 or 500 ml? What you need to understand is that we put 300 ml and we do not put any saline or something like that. You basically give air. Okay, so what you basically put a air inside this particular Singh-Steichen Blackmore tube gastric balloon. Now, how does it work? So to begin with, you basically put around 50 ml of air. Okay, so first you basically put 50 ml of air, then you pull the balloon up. So when you pull this particular kind of Singh-Steichen Blackmore tube up, this particular balloon gets entrapped at the like esophagogastric junction. Okay, it is kind of getting entrapped over there, and then what you do, you put additional 250 ml of air, and this is basically helping you create a tamponade effect. So ultimately, you end up putting 300 ml of air in the Singh-Steichen Blackmore tube, the gastric balloon, in order to create an adequate tamponade. Okay, I hope you got this, guys. Everybody understood this? Right. Now, let us move on to the next question. So, what is the most commonly used approach for the retrosternal goiter? Okay, so is it like a transthoracic via the second intercostal space, transthoracic via the fourth intercostal space, transternal through the anterior mediastinum, or the transcervical? What do you think, guys? What is the most commonly used approach for the retrosternal goiter? Now, the answer to this particular question is a transcervical, guys. Okay, what is the answer? It is a transcervical. So please understand, the retrosternal goiter, this can be either primary or it can be secondary. Now, what do you understand by the primary retrosternal goiter? Primary retrosternal goiter is something which is starting its development in the mediastinum. So it kind of starts in mediastinum. Do you get this? So this is basically it starts in the mediastinum. What about the secondary retrosternal goiter? Secondary retrosternal goiter, it starts in the neck and then it comes to lie in the mediastinum. So because of this, what is happening? The blood supply of the secondary retrosternal goiter, that is from the neck vessels. And that is why, and this is much more common than the primary. And that is the reason why you have to go for a transcervical approach. So if I told you, even if you go for a transcervical approach, you will be able to kind of control the blood vessels from this particular point, and this will not lead, like you will be able to operate even via the transcervical approach. I hope you got this, right? So the answer is transcervical. If it all this specifically mentioned primary, then you will have to go in for a thoracotomy. Do you get this point, guys? Because here the blood vessels will be from the intercostal vessel. I hope you get this. Everybody understand this? Secondary retrosternal goiter, that is much more common. For that, you have to go in for a transcervical approach because it started in the neck and then it came to lie in the mediastinum. I hope you got this, guys, right? Okay. Now, all of the following are correct about the Barrett's esophagus except. So which of the following is not correct? Predisposes to the adenocarcinoma, columnar to the squamous metaplasia, associated with the GERD and acquired condition. Now, it is a very, very simple question. I do know that. The only reason why I've put it, because this is a repeat question from your kind of NEET PG, guys. So just understand, they tested such a basic concept in once, like recently, like I think in 2019 in the NEET PG. So what you need to understand that, what is the Barrett's esophagus? It is nothing because of the repeated kind of exposure of the esophagus because of this HCl. What is happening? The squamous epithelium is getting converted into the columnar. Okay, so the squamous is basically getting converted into columnar, which you call it as a columnar metaplasia. Do you get this point, guys? So what do you call it? You call it as a columnar metaplasia. So why? Because there is a GERD which is present. So the acid is basically going again into the esophagus and it is causing injury to the esophageal epithelium. That is what is called as a columnar metaplasia. I hope you got this. Now, obviously, because it basically leads to the Barrett's esophagus, and Barrett's esophagus can lead to an adenocarcinoma. It is a predisposing factor for it. That is our main role. I mean, that is why we have to go for a repeat endoscopy in the Barrett's esophagus to check whether adenocarcinoma is developing or not. And definitely, it is an acquired condition. Nobody has a GERD at birth. Okay, so it is an acquired condition because of the lifestyle, because of the weight and everything. We get this particular GERD. I hope you get this point. Everybody understand this? The answer is definitely that columnar to squamous metaplasia. No, we have squamous to columnar metaplasia. Got this, guys, right? I know it was a very, very simple question. The very reason I have put it, because it was asked in your NEET PG, I just wanted to convey that every question is not that difficult. They do ask simple questions as well. So yeah, buck up. You will definitely do well. Just keep your basics correct. Okay, that's it, right? So let's talk about this particular question. Cushing's ulcer. Cushing's ulcer are basically seen in what? Like, are these stress ulcers which are seen in burns? Are they kind of stress ulcers which are seen in head injury? Are these the kind of stress ulcers which you see in the hiatus hernia? Or are these the stress ulcers which are seen in depression? What do you think, guys? What is the answer? So what are the Cushing's ulcer, guys? What is the Cushing's ulcer? Cushing's ulcer are basically the stress ulcers which you basically see in the head injury. Okay. So now let us talk about the stress ulcers. You have two types of the stress ulcer. One is basically Cushing's. Another one is called as Curling's. Now, the Cushing's ulcer, how you can remember it? It is basically seen the head injury. This is basically seen the head injury. So what do you understand by this Cushing's, guys? So please understand, Cushing's means like, it sounds like crushing, right? Your head got crushed up in the head injury, something like that. So just remember, the Cushing's ulcer are seen in the head injury. This is how you can remember it, okay? Your head got crushed in the head injury, so that is why the Cushing's ulcers are seen in the head injury. In the Curling's ulcer, where do you see these Curling's ulcer? You basically see it in the burns patient, okay? In the burns patients, you basically see the Curling's ulcer. Okay. Now, another thing which is basically asked is, what about the HCl? So in the Cushing's ulcer, what is happening? There is an increased HCl secretion. Okay, that is why you're getting these particular ulcers. Now, in the Curling's ulcer, the HCl secretion is basically normal. Problem is the epithelial lining that is kind of getting weakened up, and because of this, even the normal amount of acid which is basically present in the stomach, it is causing injury to this particular epithelium, leading to the Curling's ulcer. Do you get this point, guys? Stress ulcer, it can be Cushing's or it can be Curling's. Cushing's basically means that because of the head injury, there is an increased intracranial pressure leading to an irritation of the vagus nerve. Because of this, we have increased acid secretion. Because of this, we get ulcer, which is called as a Cushing's ulcer. Okay. Now, let us move to the next thing. So there is a 48-year-old man who was brought to the emergency with a severe abdominal pain. On examination, the pulse rate was 112 per minute and the systolic blood pressure was 80 millimeters of mercury. Now, the X-ray of the patient has been shown below. What is the most appropriate management? So I'll just zoom in on the X-ray, guys. So here there is a patient who has been brought to the casualty. His pulse is, let's say, around 112 and the BP is, let's say, around 80 by 50 or 80 by 40 or something. And this is an X-ray. So what you're basically seeing in here, you're basically seeing that this is the normal gastric shadow and you are again seeing another gastric shadow over here. Okay, so just make the diagnosis and tell me what exactly is the next step in the management. Will you go in for an exploratory laparotomy, saline wash of the stomach, intercostal drainage, or IV antibiotics? What will you go for, guys? So yeah, what do you think, guys? If at all you see that the answer to this particular question is an exploratory laparotomy, bang on, you're right. Why? Very, very simple thing, guys. What is this? This is an X-ray which is showing that there is a gas under diaphragm. Okay, so it means that there is some or the other visceral perforation. Okay, so right, so we have a visceral perforation here which is indicated by this gas under diaphragm. This is usually not present. This will be present only if there is a gas which is kind of leaving the stomach or leaving the intestine and entering into the peritoneal cavity. Do you get this point? So this is basically called as a gas under the right lobe of diaphragm. And here obviously you all know that you will have to go in for an exploratory laparotomy and you will have to repair whatever the viscera has kind of ruptured or something. So you will have to go in for an exploratory laparotomy over here. Got this point, guys? Right. I hope you got this. So that X-ray, that is important, you need to remember. Now, the next question, this is again a simple one. Identify the surgical blade which you will basically use for incision and drainage. So what kind of a surgical blade do you use for the incision and drainage? Do you use the blade number 11, 15, 22, or 23? What do you think, guys? What is the answer? Now, if at all you guys say that the answer to this particular question is blade number 11, you're absolutely correct. Okay, so these are all the surgical blades which we have. Let us kind of see them. Okay, so let's kind of have a look at them. So blade number 11, what is the name of this? This is called as a stab knife. Okay, it's called as a stab knife. How do you use it? This is basically something which is used for the incision and drainage. What are the other indications of using this kind of stab knife? We also use it when we are trying to go in for a tracheostomy. In the tracheostomy procedure, what we use it? We use a stab knife. We also use this if at all we have to go in for an arteriotomy. Arteriotomy. What do you mean by arteriotomy? You have to put an incision on the artery and you want to kind of enter inside the lumen of the vessel. You have to go in for arteriotomy. Please remember this arteriotomy because this is an indication which is given in your 11 Bailey, so you need to kind of focus on this. Okay, please remember this. Now, the another blade was blade number 15. What is the name of that? It is called as a D knife. Okay, it is called as a D knife. What is the use of a D knife? Where do you use a D knife? So at any place where you have to go for a precise incision, okay, where you have to go in for a precise incision, we go in for a D knife, guys. Okay, please understand this. Blade number 15, that is a D knife which we use where you have to go in for a precise incision. That is very, very important. I hope you get this point, right? Now, lastly, we talked about the blades number, let's say 20, 22, or like 21 or whatever. These are basically used for the debridement. For the debridement, if at all you want to use some blade, you will use this. Okay, so I hope you get this particular point, guys. 11, that is a stab knife which we use for arteriotomy, tracheostomy, or something like that. This is basically something which used for the precise incision, where you want to give a precise incision. 20 to 23, these are basically used for the debridement. I hope you get this, right? Now, let's move on. Which of the following statement is not true about the tamoxifen? So it is used in the visceral metastasis. Tamoxifen is useful in the postmenopausal, and aromatase inhibitors are basically used in the premenopausal woman. Dose is 20 milligrams for 5 years, and it can cause endometrial carcinoma. So what do you think, guys? Which of these is not true? Okay, so yeah, again a pretty simple question, guys, but this was again tested in the same year, like NEET 2019. What exactly is this? Okay, so can you please help me with this? Now, maybe you do not know what is the dose of tamoxifen and everything, but still you can arise at answer. Now, answer to this particular question, no doubt, it is type B. Why? Because when we talk about the hormonal therapy, guys, okay, when we talk about the hormonal therapy, there is a very, very basic concept. If at all there is a pre-menopausal woman, we use SERM. What is SERM? We have tamoxifen. Tamoxifen. And in the post-menopausal, we basically use an aromatase inhibitor. Why? Because the peripheral conversion of the androgen to the estrogen with the help of an enzyme aromatase, that is the only way of formation of a estrogen in the postmenopausal woman. Do you get this point, guys? So in the premenopausal, we have to go in for a SERM, that is a tamoxifen, and in the postmenopausal, the only way in which the kind of estrogens are forming, that is the peripheral androgens are getting converted to the estrogen because of the enzyme aromatase. So that is why it is called as an, like, that is why we use aromatase inhibitors in there. Do you get this point, guys? Do you get this? Right. So answer is typically B. There is a tamoxifen and useful in the postmenopausal woman, and aromatase inhibitors are used in the premenopausal woman. No, not right. Premenopausal woman, you will use tamoxifen. In the postmenopausal woman, you will use aromatase inhibitors. I hope you get this point, guys. Okay. Right. The moving on. The drug which is basically used for the metastatic carcinoma pancreas. What is the drug which we use for the metastatic carcinoma pancreas, guys? The answer to this particular question is it a sorafenib, sunitinib, gemcitabine, or streptozotocin? Now, for the metastatic carcinoma pancreas, we will basically use gemcitabine, guys. Okay, gemcitabine. Please remember this. Now, there are certain drugs which you need to remember. Please follow this particular list. So, yeah, if at all there is a metastatic hepatocellular carcinoma, what is the drug which we will use over here? We use sorafenib. Now, this has already been asked as an MCQ. Repeat MCQ, very, very important. Metastatic HCC, we will use sorafenib. Now, if at all they give you metastatic renal cell carcinoma, here you will prefer to use sunitinib. If at all there is a kind of a metastatic pancreatic carcinoma, you will use gemcitabine. Do you get this point, guys? So just remember these, okay? And streptozotocin, this is basically used for insulinoma. Okay, so just remember these three are very important. They can definitely ask you. They have already asked you about the metastatic HCC. Metastatic RCC, yes, sunitinib is a drug. Metastatic pancreatic carcinoma, gemcitabine is a drug. I hope you get this point, guys. Okay, everybody got this? Okay, great. Now let's move on and let's talk about the next question. So parathyroid autotransplantation. Now we all are kind of humans, right? We all can commit a mistake. So if at all while doing a surgery, you're wanting to remove, let's say thyroid only, but accidentally you remove the parathyroid. Okay, or let's say you are operating for a parathyroid hyperplasia. You do not want to remove all the parathyroid. You want to remove kind of 3.5 glands and you want to keep the half gland. In these particular conditions, where will you put this parathyroid gland? Like, so that is what is called as a parathyroid autotransplantation. Where will you do that? Will you do it in the brachioradialis, biceps, triceps, or the sartorius? Can you please help me with this, guys? Now, answer to this particular question is we will do it in brachioradialis muscle. Please understand this, guys. Okay. So, parathyroid autotransplantation. This is basically done in the brachioradialis. Please understand this. Why? Because it is easier to manage the levels of the parathyroid gland over here. If at all we want to reoperate or something like that, it is very, very easy to just operate on the arm. Do you get this point, guys? Just remember, it is a repeat question. Again, it can be asked to you. Auto transplantation of the parathyroid, it is basically done in the brachioradialis. Everybody got this point, guys? Everybody got this? Yeah. Please remember this. Okay. Now, do I have more? Right, I have more. So what is this particular investigation? So I'll just zoom in, guys. So can you please help me with this? What is, just have a look at this. I'm not asking you to diagnose it. I'm not. What I'm trying to ask you is, what is this particular investigation? Is it a CT angiography? Is it a CT MR angiography? Or like, is it a MR angiography? Is it a DSA? Or is it a 3D reconstructed CCT, guys? What do you think? I'll just move this way so you can have a look at the image. What do you think, guys? What is this particular investigation? So if at all you say that this is a digital subtraction angiography, you're absolutely correct, guys. Please understand, right? Okay. So why this is a digital subtraction angiography? As you can see, that only thing which is visible to you is the vessel, right? All the surrounding soft tissue, it has been subtracted out of the image. That is why it is called as a digital subtracted angiography. Do you get this point, guys? So that you can have a minute details of the vessels into consideration. This is what is the DSA, digital subtraction angiography. Right. Now, it is not a CT angiography. Do not get confused with this. Okay, CT angiography is a bit different. Here you have subtracted the entire soft tissue out of it, and that is why it is a digital subtraction angiography. And yes, what is the diagnosis over here? What is the diagnosis? The diagnosis in this particular condition is, what is it? Yeah, fibromuscular dysplasia. So basically what you're seeing over here is the kind of like beads appearance, okay, string of beads appearance. So these are the beads which are available, and that is what is causing a renovascular hypertension. The cause is fibromuscular dysplasia. Okay, everybody got this? Yeah, that's the thing, right? So yeah, let's talk about the next question. So what is the most common indication of a liver transplantation in the children? We do know the indication for the liver transplantation in the adults. Is it the same for the children? Like, what is the most common indication of a liver transplantation in children? Is it the biliary atresia, cirrhosis, hepatitis, or the drug reaction? What do you think, guys? What is the answer? Right. So I'll get back to you, Susmita. Just give me 1 minute. Let me just deal with this particular question. I'll get back to you. So yeah, uh, what is the indication of a liver transplantation in the children? Please understand the most common indication of a liver transplantation in the children, that is biliary atresia. You need to remember it, guys. Okay, biliary extrahepatic biliary atresia, extrahepatic biliary atresia. That is the most common indication of a liver transplantation in the children. You need to remember this, guys. Okay. Hope you got this. You need to remember this. Now, somebody's asking, like, how will you distinguish between a digital subtraction angiography and the CECT? Now, just understand one thing. In the CECT, you will have the enhanced, this is a kidney, right? This is a kidney. So where is the parenchyma? Where is the cortex? Where is the medulla? In the CT scan, you will see all those things, right? Now here, what you're basically seeing, the entire soft tissue has been subtracted out. That is why it is a digital subtraction angiography. Are you able to appreciate it? Visually, how will you distinguish? So this is a kidney, right? So you will have to look the cortex, the medulla, something like that. Are you able to appreciate over here? Nothing. That is why it is a digital subtraction angiography. I hope you got this, guys, right? I hope you got this. Right. Let's move on and let's talk about the next question. So next question is basically, right. So here I'm trying to ask you the diagnosis. So here you have a patient, and yeah, this is the image of this particular patient. Can you please tell me, guys, what is the diagnosis of this patient? Just look at this. Like, what is this? This is basically again a angiography. I'll give you this. Okay, what is this? This is an angiography of the lower lip. Of the lower lip. Can you please help me, guys? What is the diagnosis of this particular patient? So, yeah, the diagnosis of this particular patient is, what is it? It is a peripheral vascular disease, guys. Okay, what is this? This is a peripheral vascular disease. What you're basically seeing in here, you're seeing a corkscrew collaterals. Okay, so this is what is a corkscrew collaterals. So that is a characteristic thing, guys. What you're basically seeing, these are the corkscrew collaterals, and this is the diagnosis is a peripheral vascular disease. Do you get this point, guys? Very, very important. What is an investigation of choice for the peripheral vascular disease? Again, a 4-vessel angiography. That is investigation of choice. What you're basically seeing in here, this is the corkscrew collaterals. Got this, guys? It is not the varicose vein. That's what I'm trying to tell you. It is not at all a varicose vein. What is it? It is a peripheral vascular disease, PVD. I told you that it is an angiography. I did not tell you that it is a venography. It is an angiography. What you're basically seeing is a peripheral vascular disease. Do you get this point, guys? This is a peripheral vascular disease. Everybody got this? Yeah. That's it, guys. It is not at all a varicose vein, guys. All of you guys are answering at a varicose vein. It is not a varicose vein. Okay. So I hope you got this, guys. Just stay with me. I'll just before see what I'm going to do. I'm going to revise this particular thing for you. But I know that like some of you guys kind of just leave this particular thing at this moment of time. So what I'm going to tell you is that this is a kind of a thing which I've started today. I'll be continuing with this TND sessions for the next 6 days. So from July 1st to July 6th, every day morning 12 p.m. I'm going to come live, and you will be kind of having this particular TND session. So if at all you wish to come and attend it, please do come. We will be having some fun with that. Okay. So before you guys leave, I'll just revise because I personally feel that it is always important to consolidate things. So what I'm going to do, I'm just going to revisit every question and just trying to tell you what exact concept which you learned in that particular question. So it will be kind of a revision for you guys in like 5 minutes, and then we'll be kind of signing off. So let's move on, guys. So we started with just right. So we basically started with the first question where I asked you that the full thickness graft, from where we cannot take it. So we can take it only from the places where we have a redundant skin. So we do not have a redundant skin in the scalp, and that is why we cannot take a full thickness graft from the scalp. So that was a basic thing. We can take a full thickness graft from only those places where we have an extra or a redundant skin. Now this was a very, very simple question. It is just that we always read that 1 French is 0.03 millimeters. If you convert it into centimeter, it is 0.03. Okay, it's 0.33 millimeters, and if at all we convert it into centimeters, that is 0.03 centimeters. Okay, just a simple math question. Just remember that. Important, 1 French is equal to 0.33 millimeters. Right. Now, then we talked about this particular thing. So I told you that this particular image, because this part of a thyroid is not taking a iodine scan, that is why it is a cold nodule. I told you that the risk of malignancy in a cold nodule, it is 15 to 20%. A risk of malignancy in a hot nodule is 3 to 5%. So this is again something which you need to remember. Then I told you that if at all there is a patient who is coming to you, he's stable, but if at all you do the examination of the abdomen of this particular patient and you find that the patient is basically having a signs of peritonitis, okay, then you don't need any other investigation. You do not need FAST, you do not need CT scan, you just need to go in for a exploratory laparotomy. The next step in this management of this particular patient would be exploratory laparotomy, okay, right. Then what I told you that just a simple Wattersons criteria, where do you use it? You use it for the tracheoesophageal fistula. Okay, got this? Wattersons criteria is basically used for the tracheoesophageal fistula. Then I told you that Dolman surgery. Okay, the Dolman surgery, this is basically used for the endoscopic stapling of the septum. Remember this endoscopic stapling of the septum, it is done by the Dolman surgery. This is basically used for the Zenker's diverticulum. This is how you do it. That stapler, endoscopic stapler, had 2 prongs. One goes inside the kind of diverticulum, one goes inside the esophagus, and then we shut it up. The staples basically get rid of this particular septum, and you have the kind of a continuously or something like that. Okay, hope you got this. This is what is a Dolman's procedure. Then I told you that, this is something important. So we have 3 kinds of things which happens in the esophagus. So if at all there is a herpes simplex virus esophagitis, what you get a punchedout ulcer. If at all there is a kind of a CMV esophagitis, what you get a serpiginous ulcer. But these 2 things are on the endoscopy. Now, if at all you kind of have a candida infection, what you get is a shaggy appearance of the esophagus. You get this point, and this is what you get in the barium swallow. I hope you get this point, guys. Okay, why this is important? Because it's an important differential diagnosis of a varicose vein, esophageal varices. Okay, right. Then I told you that in the zinc stick in Blackmore tube, overall you will have to put around 300 ml. First, you will put 50 ml. You will pull it up. It will get stuck at the esophagogastric junction. You will put extra 250 ml to facilitate the tamponade effect. So ultimately, you will put around 300 ml in the gastric balloon. Okay, in the gastric balloon in the zinc stick in Blackmore tube. Okay, I hope you got this. In the zinc stick in Blackmore tube, how much amount of the air will you put? You will put 300 ml in the gastric balloon, right? Now, I told you that the retrosternal goiter, it can be the primary or secondary. The primary, it rises in the mediastinum, so that is why we have to go in for a thoracotomy. The secondary, it starts in the esophagus and then it comes down to lie in the thorax, and that is why we can even go for a cervical approach. Cervical incision can be given in this particular thing. Okay, I hope you got this. Then I told you that, what did I tell you? Right. So it was a very, very simple concept. Because of the GERD, what can happen? The squamous epithelium can transform into the columnar epithelium. We call it as a columnar metaplasia. It can give rise to the Barrett's esophagus, which is a predisposing factor for the adenocarcinoma. So a basic concept, which all of you guys know. I talked about the stress ulcer. So there can be two types of the stress ulcer. It can be a Cushing's ulcer or it can be a Curling's ulcer. Cushing's ulcer, this is basically present in the head injury. This is because of the increased HCl secretion. Curling's ulcer, they are basically seen in the burns patients, which is because of a normal HCl. Even if there is a normal HCl, we can still have a Curling's ulcer. Then I talked about a pretty simple thing. The only point I was trying to make, just appreciate this particular X-ray. You need to, it's a very, very simple thing, but you need to understand that if at all there is a gas under the diaphragm, it indicates that there is a visceral perforation. You have to go in for an exploratory laparotomy and correct whatever the perforation is there. You get this point, guys? So gas under diaphragm, visceral perforation, straight away laparotomy. Exploratory laparotomy, right? I told you that there are three types of knives. So we have a blade number 11, which is a stab knife, which we use for the incident drainage, tracheostomy, and arteriotomy. I told you that 15 number knife, which is basically a D knife, which we use whenever we want to give a precise incision. And yeah, like 2022, like 2022, 21, whatever, these basically we go in for a debridement. Okay. So I hope you got this. Then I told you that in the hormonal therapy, what do we have? We have a premenopausal woman in which there is, let's say, if at all there is a SERM. In the premenopausal woman, as a part of the hormonal therapy, we basically use a kind of a SERM. And this is basically the tamoxifen. Okay, I hope you got this. Postmenopausal woman, what do we have? We have aromatase inhibitors. Why? Because in the postmenopausal woman, the only source of the estrogen, that is a peripheral conversion of androgen to the estrogen. That is why we have to use a aromatase inhibitors. Lastly, okay, so in the carcinoma pancreas, what is the drug that we use? We use gemcitabine. You know that. For the metastatic HCC, we use sorafenib. For the metastatic RCC, we use sunitinib. For the metastatic pancreatic carcinoma, we use gemcitabine. I told you that if at all we want to go in for an autotransplantation of the parathyroid gland, we can do it in the brachioradialis muscle. Okay, so in the brachioradialis, we can autotransplant the parathyroid glands. This I just asked you about the what is this particular investigation. This is a digital fracture angiography, and the diagnosis is kind of string on beads appearance, which is basically for what is it for? It is basically for the fibromuscular dysplasia leading to a renovascular hypertension. Right, and then I talked to you about what is an indication of a most common indication of a liver transplantation in the children. We saw that it is a extrahepatic biliary atresia. Last question which I had, which I think many of you have doubts in this, so please understand, guys. First, what is this? This is a four-vessel angiography, four-limb angiography. Okay. Now, what you'll basically appreciate over here, this is a corkscrew appearance. What you're seeing, this is a corkscrew appearance. And this is what you get in the peripheral vascular disease, guys. Very, very important. Please remember this. It is an important image. I hope everybody got this, guys. Okay. So, well, somebody's asking like Cushing's and Curling's ulcer, what is the most common site? It occurs in the stomach. Okay. It basically occurs in the stomach. Both these kind of ulcers, they occur in the stomach. Okay. I hope you got that, right? Okay. That's it, guys. That's it for today. I hope you like this particular session. And if at all you wish, you can come and join me. This T&D will continue. Like this is going to continue from the 1st of July till the 6th of July. Every day, I'm going to take it at 12 p.m. So yeah, hope to see you there. And guys, thank you so much. I hope you like this particular session, guys. And if at all you like this, I'm sure that you will like our plus subscriptions, because in that the courses are much more structured. You will get unlimited access to so many awesome things. We are coming up with a revision course. We are coming up with a crash course. We are coming up with a 6-month AIMS course. We are coming up with lots and lots of courses. So please click on the kind of a link below. Go to my page, explore it while you're there. please follow me up. And yeah, so that you will not miss any of the notifications, and you can browse through all the courses. And if at all you wish to join any of them, that's great. I'll be more than happy to connect with you on the Plus platform. If at all you wish to take any of the subscriptions, please consider using my promo code, that is dr.pawan. Okay, if you use this, you will get around 10% off. If at all you're someone who is preparing for NEET PG 2021, if you take, let's say, around 6 months subscription, it will be close to 16K, but the value it will add to your life, it is going to be very, very great. Thank you so much, guys. It was indeed a pleasure interacting with you. Have a great day, happy studying, and at the same time, while you're here, please hit this video a thumbs up, and please subscribe to our channel, and so that you do not miss any of the contents. Thank you so much, guys. See you around.